Good afternoon. My name is Stephan Kemp, and it's an honor to be asked to present to you the LXTLC online conference, the Family Weekend. And the topic of my presentation is newborn screening for adrenoleukodystrophy. In 2004, at the National Advisory Committee for Newborn Screening in the United States, Hugo Moser said that ALD newborn screening would save lives. And the rationale for this is that ALD can present as three different forms. Adrenal insufficiency that can start in boys already at the age of 6 months, but already in adulthood. Cerebral ALD, so an inflammatory reaction in the brain that is seen in boys starting after the age of 3 years. And in adulthood, males and females develop a spinal cord disease or myelopathy. And this happens in all males that do not develop cerebral ALD, and at least 80% of the women with ALD are developing spinal cord disease. And the rationale for ALD being added to newborn screening is that for adrenal insufficiency and for cerebral ALD, there's a treatment available. Adrenal insufficiency, if it's not treated, it can be life-threatening. And this form of the disease can be treated effectively with hormone replacement therapy. However, this form is often discovered only after several hospitalizations. And for cerebral ALD, untreated cerebral ALD is often fatal. And a hematopoietic stem cell transplantation or a bone marrow transplant is curative. But this is only curative when it's done in the early stage of the disease. In other words, patients who are diagnosed on the basis of neurological symptoms are already too far advanced in the disease course for a transplantation. And this is also illustrated by a study from the Kennedy Krieger Institute in Baltimore from 2007, where 283 boys that were diagnosed with cerebral ALD, those charts were investigated, and out of these 283 boys, only 19 were eligible for a bone marrow transplant. So the majority of these boys were diagnosed too late. But saying that the disease has to be added to a newborn screening program and providing a clear rationale for this is one thing. What's also needed is a biomarker that allows diagnosis of a disease at birth. And when a patient is suspected to have adrenoleukodystrophy, a blood sample is drawn, it's sent to the lab, and in plasma or in blood, varying chain fatty acids are analyzed. This is not an option in newborn screening because this procedure takes too long. So what's needed is a biomarker that can be measured in this tiny amount of blood that's drawn from a heel prick and is provided on a blood spot card. That was not possible at that time. So what the team in Baltimore set out to do was identify a biomarker that's available in a heel prick blood, and that is sufficient, that is good to diagnose ALD. And the team identified C26 lysophosphatidyl-choline, or C26 lyso-PC. And when you measure this in blood spots from controls and from ALD patients, you see that there's a clear increase in ALD patients. So there's a rationale for ALD being added to newborn screening program. It can be diagnosed at birth, but that doesn't mean that a disease automatically is included in the newborn screening program. There's a third thing you need, and that is a commission that adds this disease to a newborn screening program. And for that, we have to acknowledge the phenomenal work by Elisa Seeger. Her boy Aidan was diagnosed too late for a bone marrow transplant. And when Elisa found out that the newborn screening test is available, she made it a task to have ALD being added to a newborn screening program. And Aidan's law, which is a law in New York State, was approved in February 2013. And the state of New York started newborn screening in December 2013. And we also have to acknowledge the work from Joe Orsini, the New York State NBS lab, who made it happen, that this test could be included in mass screening, population screening, because there's a huge number of samples every day that has to be analyzed. Since then, several states in the US have been added to the newborn screening program. This is the map of 2020. And 17 states are now screening for adrenoleukodystrophy. That means that in the US, every year, over 2 million babies are being screened for adrenoleukodystrophy, and that's more than 50% of all the newborns in the United States. And it is expected that in the coming years, more states will initiate ALD newborn screening. So what does it mean? Over the years, since the start of ALD newborn screening in the US, more than 4 million newborns have been screened for ALD. This has resulted in the identification of 113 boys with ALD and 131 girls with ALD. And based on these numbers, we can calculate the prevalence or the incidence of the disease, and that is 1 in 17,000 newborns. This is information that was provided by New York State at the ALD Standard of Care meeting last January in New York, because New York State has the longest history for newborn screening. And this far, 2 boys have already been referred to a bone marrow transplant. So these boys had received a bone marrow transplant in time. And 5 boys are already on treatment for adrenal insufficiency. So I'd like to move to the Netherlands. In the Netherlands, this is the number of diseases that were screened until 2011. And in 2013, the Dutch Health Council had plans to expand the Dutch Dutch newborn screening program. And so there was an opportunity for Mark Engelen, my colleague, and me to nominate ALD. So we did that. And but interestingly, at that time, when the Dutch Health Council had these plans, they used a list from the United States, which is the US Recommended Uniform Screening Panel, or the RUSP, and the version of 2011. And on that list, ALD was not included. But we knew that in New York or in the US, there were going to include ALD in the newborn screening. And we, of course, we have very close collaboration across the globe with all our colleagues, and we were allowed to use the information that our colleagues in the United States had used. And also with the help of Patrick Aubour, we provided our paperwork and the rationale and all the numbers and everything you need for a nomination of a disease. And in September 2013, we presented our case to the advisory committee of the Dutch Health Council. And it took a while. And on April 8, 2015, the Dutch Health Council published their new recommendation to the Minister of Health. And this is a copy of the letter that the Minister of Health sent to the Parliament within a week. She took over the advice or the recommendations. And in April 2015, 14 new conditions were added to the newborn screening panel. However, these conditions cannot all be added at once, because I like to compare newborn screening with a slow moving train, and every disease is a wagon, and this train has to go on a certain pace. And if you add too many wagons at once, there's a chance either for the train to derail or for the train to lose pace, and that's not an option. So you can add a cart, but the train has to keep moving. So what happens in the Netherlands is that every year, 1 or 2 or sometimes 4 diseases are being added to the newborn screening panel. This is the guidelines from the International Society for Newborn Screening that reflect the conditions, the criteria that a disease needs to fulfill in order to be a candidate for newborn screening. And the first criterion is that early diagnosis must be directly beneficial to the neonate. That's a very important point. And that's also a very important point for the Dutch Health Council, because they argued that this is true for boys, because boys can develop adrenal insufficiency, boys can develop cerebral ALD, but boys do not, but girls do not develop any of these two conditions. So this is a copy of the text from the report. It says that screening for ALD is only useful in male newborns because the symptoms in women usually arise later and cannot be treated. So women do develop spinal cord disease, but there is no treatment for spinal cord disease, and this is not a disease that has an onset in the neonatal period. So therefore, the committee recommends to only screen male newborns for ALD in the newborn screening program. So in the Netherlands, only boys would be screened for ALD, which is in contrast to the United States, where all newborns are being screened. And that's interesting because gender-specific screening has not been implemented before in any newborn screening program worldwide for any disease. And this requires a pilot study. And that's the SCAN study. And the SCAN study started in 2018. And this is the logo and the acronym for SCAN is Screening op ALD in Nederland, or in English, Screening for Adrenoleukodystrophy in the Netherlands. Newborn screening in the Netherlands, this is the map of the Netherlands, which is divided in 12 provinces. And these, for newborn screening, they're divided in 5 regions, so indicated by the different colors. And all these 5 regions have their own newborn screening lab. And the SCAN study is a pilot study, and it includes 2 of these provinces, the one in pink and the one in orange. And it will continue for at least 12 months, and we will screen at least 70,000 newborns. And the primary aim of the study is to develop and test a boys-only algorithm. But that's a challenge, because how do you set up a boys-only newborn screen? There's no other, as I said, there's no other screening anywhere in the world that we could look at. So we had to develop this from scratch. So we had to come up with a test that would identify males using this little bit of blood. And I'll explain it on the net, yeah. And also so you can detect other diseases that are untreatable for Klinefelter syndrome, Turner syndrome, but also peroxisomal diseases for which there's no treatment available. And also the task that was given to us is set up a screening algorithm that diagnoses boys with ALD, but not any of these other conditions. And all this, again, in this mini tiny little bit of blood spot of 3.2 millimeters. So if you think, well, it should not be that hard to pick up the boys, because here this is a Dutch card, but these little 2 checkboxes here says male, female. So why do you not select all the cards that have the information male? So we looked at the information provided on these cards, and then turned out that on a monthly basis, about 4% of the cards are either not filled out correctly or incomplete for whatever reason. What also is true that sometimes the gender of the newborn is unclear at birth. So this is not an option. So we have to do it in another way. And for that, we decided to start counting chromosomes. And then we can make use of the fact that males only have one X chromosome and a Y chromosome, and females have two X chromosomes. So if you think of the ratio of these autosomes, or chromosome 1, chromosome 2, for which all of which we have two, or a pair, and you think of the ratio of for example, chromosome 3 to chromosome X, then in a male this is 2 to 1, and in a female it's 1 to 1. And there's a genetic test that you can do, because there's a little piece of DNA on the X chromosome, which is also present on the chromosome 3. And you can look at it, and then you will, in the male case, you find 2 to 1 ratio, and the female 1 to 1. But of course, this test can fail. So what we did, we expanded it to 3 tests. So we do this test 3 times in a single analysis. And this looks like this. In a male, you have this high peak, which is in this case chromosome 7, and then this lower peak chromosome 1. This is a ratio 2 to 1. And in female, they are equally high, so it's a 1 to 1. And in this way, you can distinguish boys from females, or individuals with one X, and you can you can select the cards coming from an individual with one X, and they will go on to the next step in the analysis. So this is on top. We see the screening algorithm that is from New York State. So what happens is that a newborn blood spot arrives at the laboratory. Then there is a quick method. That's a method in which also for other diseases analyses are being done, and this is a very quick method, but it's not so sensitive. So when these are positive, they go out, they go to the next step, and this is a much more sensitive test, but it takes longer. So you cannot run all these initial samples with this test. It would take too much time. And it turns out that 99.5% of the cards that are positive here in tier 1 are turn out to be false positive when they are reanalyzed with tier 2, which is very sensitive. And the cards that are positive in tier 2 go to tier 3, and that's the sequencing of the ABCD1 gene. If there's a mutation in this gene, it's an individual with adrenoleukodystrophy. And in the United States, if there's no mutation in the ALD gene, additional DNA analysis are being done in order to verify whether this individual has any of the other diseases that are diagnosed with elevated levels of C26 lysyl PC. Well, in the Netherlands, we only are screening boys, so we start with the same tier 1, and then the cards that are positive go to the X counter. And only those with 1X go to the 3rd tier. And the ones that are still positive, they go to sequencing of the ABCD1 gene. And only if there's a mutation, it's a boy with ALD. And if there's no mutation, we have to stop testing, because we are not going to diagnose any of the other diseases. This is the very complicated scheme of the Dutch newborn screening. So what happens here is that when a couple is expecting a newborn in the 3rd trimester of the pregnancy, they are offered information on newborn screening. And now on top of that, they also receive, in the participating regions or provinces, they also receive an information brochure on ALD screening. When the child is born, it's registered at City Hall, and again, the family receives this brochure. Then a signal goes to a central registry, and then the screeners in the neighborhood of the newborn are informed that there's a newborn and that the heel prick has to be taken. The heel prick is taken, it's sent to the laboratory. These analyses are being done. The information goes again to the same system, and in case if it's normal results, in the past you would not hear anything. This is changed now, so everybody will receive a letter. If it's a normal result, it's a normal result. If it's if it's a screening positive result for any of the conditions that are part of the newborn screening, then we go to the next step. And so we do this different for ALD, because for ALD we have some time. So we have decided to make this final step patient and family friendly. So what happens is that the medical advisor of the newborn screening program contacts the pediatricians at the Amsterdam University Medical Center. And then the medical advisor contacts the general practitioner of the family. In the Netherlands, it's known, every family, the connection between the general practitioner and the family is known in the Netherlands. So the medical advisor can identify the general practitioner of the particular family, and there's information to the general practitioner that a screen positive individual is being born. So then it's the task of the general practitioner to contact the family. And during that meeting, there is a possibility to call the pediatrician at the Amsterdam UMC. And we, as I said, we want to do this patient and family friendly. So this contact will never be done on a Friday, because what happens if you do it on a Friday, the family is giving this horrible message, and there's a weekend, and of course, what do people when they hear something? They go on the internet, and we want to take Dr. Google out of the equation. So this meeting between the general practitioner and the family is scheduled either on a Monday, a Tuesday, or a Wednesday, or a Thursday. And already an appointment is being scheduled without the family being known for the next day. So the next day, the family will meet with the pediatrician, and they can ask all the questions that they have. And the follow-up of the newborn is being initiated. What I also want to say is that the whole newborn screening, as well as the follow-up and the treatments that are needed, in the Netherlands are covered by health insurance. And that is one of the reasons that we pay a lot of tax in the Netherlands. It's also, maybe not, maybe I did mention it, information in newborn screening is very important. Newborn screening in the Netherlands is done on the basis of informed consent. So next to the brochure, we also developed a website with all information. It's in Dutch, but all information for parents, families, but also for healthcare providers and screeners. This whole algorithm that I just described, and the study is also being published. And so if you go, it's in open access. So if you go to Dr. Google and you type in either Frontiers, adrenal leukodystrophy, or the X factor, you will find this paper and you can download it for no cost. And then one of my final slides. So now we have, in the Netherlands, we have newborn screening, and the United States are also starting with, there are 17 states that have started newborn screening. But that's not the end. So there are challenges, still challenges. So in contrast to the United States, in Europe, we do not have a RUSP list. So there's no list in Europe that contains all diseases that should be included in newborn screening programs. So there's no harmonization among European countries. Some countries only screen for one disease, and that's always PKU. That was the first disease for which newborn screening was developed. And other countries screen for more than 30 conditions. What also needed is now that we can identify boys and girls at birth. We need to standardize the protocols for follow-up and counseling of new patients and families. For example, at which age do you start MRI monitoring, and at what frequency? This is a more technical thing. Is sometimes you do not find a pathogenic mutation, but you find a variant that is new. So how do we deal with that? That is a very important point. And then, of course, there is this difference between the United States and the Netherlands. Do you screen either boys and girls or only boys? And yeah, each country makes different ethical considerations. And we think that the Dutch algorithm offers a solution for those countries that make the same ethical consideration as the Dutch Health Council has done. This is a huge project, and these are all the people that are involved in the SCAN study. And this is the ALD team at the Amsterdam University Medical Center. And I thank you for your attention.